Hi, my name is Rafael Fonesca. I'm a hematologist at the Mayo Clinic, and I'm delighted to be here with this distinguished panel. We have three of the speakers at our session today for the Myeloma 2018 meeting. Dr. Jeffrey Wolf from UCSF, Dr. Faith Davies from UAMS, and Dr. Dirk Hose from Germany as well, too, who join us today to talk about some of the topics that were discussed this morning, particularly with an emphasis on personalized medicine. We held a discussion at the end. What is the progress that has been made, and a little bit tongue-in-cheek, has it been a bust? We don't think so, but how do we move the ball forward? So maybe I want to start with Dr. Wolf. As a clinician, you have extensive experience. What are the lessons that we're learning from the approach of precision medicine, knowledge about mutations and so forth when it comes down to the management of myeloma patients?
Well, I've been practicing long enough to realize that the progress we make in the laboratory doesn't immediately translate into the clinic. I think that there's tremendous promise in the concept of looking critically at a patient's mutational status, finding the key points, the key mutations, and trying to drug those, that is, to interfere with these mutations. But I think that we're still far from making that a reality. The impediments to that these days are firstly to get the mutational analysis, to find the drug, to get the drug authorized by insurance, for example, to apply the drug, in which case there certainly are side effects, and it's also possible that that drug may only affect 30% of the patient's malignant cells, so that you may ultimately have to combine it with other therapies. So I think we're still a long way away. I don't think it's been a total bust, but I think that that always the science is ahead of the clinical ramifications.
Yeah, I totally agree with you. A bust would be almost like give up. I think no one wants to give up. I think we've made some progress, particularly with prognosis and the understanding of some of those markers. Maybe we should go to Dr. Davies too as well. You have worked on this, for many years, of course, have led some of the most important efforts to think about the integration of mutations and genetic markers. If you had that ability to predict into the future, what are the steps that are going to allow us to move that knowledge into practical applications?
Yeah, no, so I think that we've, over the last few years, have really refined what we know about the different prognostic markers. And so now it's converting those tests, which at the moment are often quite difficult to perform, require a lot of computational analysis, often require quite a bit of patient sample, and trying to get those to tests which can be utilized in the labs easily and FDA approved. So I think that's one step. But also as well, I think it's gaining a better understanding about how we maybe combine some of the targeted agents we have with some of our more general myeloma specific agents, so that we can really get the best benefit for patients. And that's going to be a little bit around kind of performing innovative clinical trials. I think we're going to have to rethink how we think about how we investigate some of these things.
Absolutely. I think your point is excellent, because you can have the knowledge, but then the practicalities, even how do we get the right samples? I mean, do we have enough cells to do the testing? What's the turnaround time? That is often underappreciated, right? You have this sort of aspiration, but then the real world makes it quite different. I mean, sometimes we even have a hard time getting results for FISH results, which we've done for over 25 years. So I think that's very, very important. Dr. Hose, let me ask you a question. You presented some very compelling data. You have access to tremendous data sets, a very large number of patients. You presented a concept that I really like today, which was, what do we know and what's kind of still in play? How would you break those? So for the audience that hears us, perhaps not everyone knows extensively about multiple myeloma. What do we know that really should be considered, and what's really in development at this point?
I think this is one of the most difficult questions to ask. So we know a little bit about the myeloma pathogenesis. We know the translocations and cyclin D upregulation being present in all of the myelomas. And we know now quite well the spectrum of mutations that can appear, but what is currently lacking is to put it all together to get a real understanding about the pathogenesis of myeloma. So are these mutations we have been talking about critical for the myeloma cells? Is this a combination of mutations which is needed? atop on the dysregulation of the D-type cyclins. And this comes back to the question of the precision medicine, because on the one hand we do not have a complete understanding of how pathogenesis of myeloma really works, and on the other hand we do not know for most of the compounds what they really specifically do, like these unspecific drugs like melphalan, or also more novel drugs like the IMiDs. So for precision medicine you would have also to have the precision weapons you use, and for how many compounds we at the moment exactly know the mechanism of action. So this comes atop on the second question.
Let me push you on one thing there. We know there's certain genetic markers that are clearly prognostic. I think you showed beautiful data during this meeting. There's some that are a little bit more predictive that relate to therapy, and there's a significant overlap between both of them. Your comments about 1Q, can you give the audience some thoughts about 1Q, 3 copies versus 4 or more, and what are the associations with other genetic markers?
Okay, so 1Q gains are copy number associated with proliferation of myeloma cells. So the more copies you have, the higher is the proliferation rate of the myeloma cells. And for the prognostic impact in our cohort of 1,400 patients, we saw that there's a copy number dependent impact on prognosis. So 3 copies are associated with adverse prognosis, but if you have more than 3 copies, the prognosis is even worse. And this plays out especially during the first 6 to 8 years of the myeloma patients.
Excellent.
And this is for the overall survival, and this I think is because of the association with proliferation which plays out.
So I do think the myeloma community at the international level has coalesced on the high-risk markers, and admittedly this can change with therapy. 414, 1416, -17, we're improving with mutation detection, but I think we need to come together with 1Q, so we look forward to your efforts in this regard. I think that's something that needs to be crystal clear for the clinicians out. I'll go back to Dr. Davies. So one of the problems is we know from the literature that sometimes patients respond. They take BRAF mutated patients, but they're short-lived. And one of the questions I was posed today, how do we integrate the ability to treat BRAF, even if subclonal sometimes, and then make that productive in the clinic, perhaps combinatorial approaches, perhaps combination with therapy? What are your thoughts in this regard?
So yeah, I think, as you say, we need to learn a little bit more about it, because one of the discussion points today was, does BRAF inhibition only work if you have 100% of the cells with the mutation? What happens if you only have 30% of the cells with the mutation? And as you say, do we just need the BRAF inhibitors on its own, or can we utilize it with other drugs as well? And what are the resistance mechanisms to it? And I think the position we're in, as you said, we're on a bit of a long journey here. The position we're in is that we now have definitive proof that targeting these mutations can cause a difference. There was some really nice data presented this morning about mutations of FGFR3 and how you could see those cells being killed off. So we've moved past the proof of principle. Now we're into the actual how we do this in reality. And I think to some extent we need to start thinking about using our precision medicine drug, but in the context of other myeloma-related drugs. So targeting the plasma cell biology and targeting that particular precision molecule. There was other discussions as well about how to date most of our precision medicine has concentrated on the actual myeloma cell and hasn't talked about the precision medicine that may be required for the bone marrow stromal and the microenvironment. Right. And I think that's the kind of next phase of studies that are going to
maybe it's not even rescuing a clone, but you can imagine a BRAF mutated, maybe BRAF plus DAR-RD is going to be, significantly better than DAR-RD for that patient population, as opposed to just thinking like an imatinib CML type paradigm. So let me finish with Dr. Wolf. A question for you. One of our founding fathers was present today, Dr. Barloghi. And Dr. Barloghi made the comment that perhaps some of the immunotherapy, specifically he mentioned daratumumab, might be able to overcome some of these high-risk features. I've seen the term thrown around before, extragenomic approaches. So presumptively daratumumab could act even in the face of some of these high-risk genetic markers. And your group has extensive experience with this type of antibodies. What are your thoughts? Can that become reality, or is it just too early to say at this moment?
I think it's certainly possible, and often Bart goes way out on a limb, which allows us to experiment in that direction. But I certainly think that we may overcome this multiplicity, this heterogeneity within the world of myeloma with some drugs that are so effective and comprehensive that they can treat the whole disease. But I think we have to continue along both pathways. I don't think we can assume that daratumumab is the answer or that CAR T cells are the answer. I think for some patients, certainly targeted therapy may be the only way to get at their disease. I'd like to actually add to what Faith was saying, and that is that one of our problems with testing the precision medicine is that we generally test it in patients who are very far along in their disease. They've had 6 or 7 lines of therapy, and they probably at that point have multiple aggressive subclones, and you may just be targeting one, and therefore one of the others is what ultimately causes their demise. And so I think we have to be studying these agents much earlier.
Well, thank you. I'm going to finish by a couple of comments and then thanking you all for your comments. The first one, I don't think it's a bust. I think we're just getting started. I think of it like we have a puzzle, we have the pieces. We kind of know where the blue pieces are. That's the sky, right? We have the gross description. We just need to start putting those pieces together. And I think the work that Dr. Davies referenced from Dr. Trudell was really, really remarkable. So, I hope we can continue to move forward. One particular area that I struggle is how do we move forward also with prognostication? And that's a challenge because the more specific we get, the smaller the group of patients that we identify. So we heard about the double hit today, 6% of patients. So the taxonomy has to be also associated with clinical relevance, right? If we had 2% of patients that clearly have the worst prognosis, they may be actionable, but then we lose the effect of risk for a larger population. So that's something we're going to have to balance out. And with that, I'm going to, again, thank you for your comments and your participation, and as well to the audience. Thank you.